Welcome to Raaonline. Today's topic is contracted pelvis. So how do we approach an obstetrical patient? We need to know her demographic details. We need to know the history, which is of utmost importance. Short summary based on history, optional, but it impresses the examiner. We need to know the general examination. We need to do the systemic examination and the obstetrical examination. We have to do the pelvis assessment, and if needed, you can mention not done. If it is an undergraduate, they can mention that they didn't do, but if it is a postgraduate, it needs to be done. Then you need to know the summary at the end of history and examination. You should also be able to tell the diagnosis to your examiner, and sometimes you may also need to tell the differential diagnosis to your examiner. You should also know the broad outline of management. Management includes investigation and treatment. So investigation and treatment together is called as management. What are the demographic details you need to collect from the patient? Age, the occupation of the patient and her husband, the place of dwelling where they are coming from, education and occupation of the husband, and income and the socioeconomic status of the patient and husband. In the personal data checklist, you need to know the height, weight, BMI, last menstrual period, expected date of delivery, gestational age of the patient. You also need to know the pulse rate, blood pressure, blood group, RH typing, and the immunization status, and whether she has a PICMI number in our state government. Registration details. History taking in obstetrics. Presenting complaints in the chronological order. History of presenting complaints should be presented in the chronological order, and history of present pregnancy if admitted for safe confinement. Menstrual history, which includes menarche, age, and the regularity of menstrual cycles. Marital history of the patient. Obstetrical history, past obstetrical history, if any, in a multigravida. Past medical history, past surgical history, family history of the patient, personal history of the patient, and the diet history of patient is important in the cases of anemia, fetal growth restriction, and diabetes. Now, in the history of present pregnancy, you should also ask if there is any ailments, if there is onset, duration of the ailment, severity, radiation exposure of the patient, if there are any associated symptoms, aggravating factors, relieving factors, and any earlier treatment taken, medical or surgical. Now, if you get a case in an exam where all you can have a discussion about contracted pelvis and CPD. If you get a short-statured gravida, if you get a primary gravida with mobile headed term, if you get a gravida with a residual polio, multigravida with difficult vaginal delivery in last pregnancy, instrumental deliveries. If the patient has big baby in current pregnancy, then also the viva can go like a CPD viva. And if it is an occipito-posterior position or a deflexed head, then also the viva can go as a cephalopelvic disproportion viva. Let's come to a case history. Mrs. Kaleselvi, 23-year-old primary gravida, is coming from Puneri, 10th grader. Studied till 10th grade, and she's a housewife, and she's at Lata operator for 25,000 per month, and she belongs to the socioeconomic class 3. She has history of 9 months of amenorrhea. She is booked and immunized at the Poneri government hospital. Her last menstrual period is 15th January 2020, and her expected date of delivery as calculated by Naegeli's formula, that is 9 months and 7 days, is 22nd October 2020. She is at the gestational age of 40 weeks today. She had regular cycles and she is admitted to our hospital for safe confinement. And in the obstetrical history, in the first trimester obstetrical history, she conceived spontaneously. Pregnancy confirmed by urinary pregnancy test at 45 days of amenorrhea. LMP 15th January 20, ED 22 October 20. No history of vomiting, spotting, pervaginum, fever or drug intake. No history of any ultrasound done in this pregnancy. The patient has taken folic acid in the first trimester. In the second trimester obstetrical history, patient felt quickening at 6th month. No history of bleeding or leaking pervaginum in the second trimester. No history of increased blood pressure in second trimester. OGTT was done in 4th month, was supposed to be normal. The patient had an ultrasound done at 20 weeks in the second trimester, which corresponds to the gestational age, and there are no anomalies found. Patient took iron and calcium regularly in second trimester. Patient had 2 doses of tetanus toxoid. The third trimester obstetrical history, patient had regular antenatal visits, no history of bleeding, drug intake, fever or draining pervaginum in the third trimester. Patient got done an ultrasound at 32 weeks which showed cephalic, which corresponds to the gestational age. Patient took iron and calcium in third trimester, and patient was able to perceive movements well in the third trimester. The menstrual history, patient had menarche at the age of 13 years, regular cycles, moderate flow lasting for 5 days. Last menstrual period 15 Jan 2020. Expected date of confinement 22 October 2020. Marital history 10 months, married, non-consanguineous marriage. Past history, no history of tuberculosis, hypertension, diabetes, rickets, osteomalacia, fractures, tumor of spine or tumors of pelvis or limb, no history of trauma or poliomyelitis. In the personal history, patient is mixed diet, bowel and bladder habits are normal. She has B positive blood group. In the family history, no family history of diabetes, mellitus, hypertension, multiple pregnancies, anomalies in the family. The only positive family history is that the mother is short stature and she has the same height as patient, and the mother, who's short stature, had 3 normal vaginal births. On general examination, patient is moderately built and nourished, no pallor, no pedal edema, temperature is normal, pulse rate 84 per minute, blood pressure 124 by 78 millimeters of mercury, height is 146 centimeters, weight is 61 kg, BMI is 28.6, patient's spine is normal, there is no limping, gait is normal, breast, thyroid clinically normal. On obstetrical examination, on inspection, the abdomen is longitudinally enlarged, umbilicus flushed with skin, stria gravidarum, linea nigra present, no engorged veins or scar marks, and hernial orifices are free. On palpation, patient has a fundal height 32 week size with flanks full at term, symphysia fundal height 34 centimeters, abdominal circumference 99 centimeters, fundal grip shows broad soft breech. Umbilical grip, one left-sided spine is felt and on the right side limbs are felt. On first pelvic grip, soft, round, independently ballotable mass suggestive of fetal head which is mobile. So in the second pelvic grip, the fingers are converging below the presenting part suggestive of non-engaged fetal head. On pervaginum examination, cervix is 3 cm long, uneffaced, soft, mid position, os is closed and head is felt through phonesis.